All right. It's the first podcast for the Traveling Doctor. I am Dr. Albert Lin, and I'm starting this up right now to kind of discuss some things and questions about coronavirus. Uh, Yeah, sorry. So people are asking how to join. This is the first time I've ever done this, so it's really tough for me to figure out how um, to do it. But basically, this is what we're going to do. We're going to talk a little bit about some of uh, the the things and the myths about coronavirus, and I guess I'll answer some questions. You're welcome to type in a comment. I think I'll get it on my screen, or you can text me or Facebook message me personally, and I think I'll get it there. Anyway, so a lot has been happening with coronavirus, and I think basically I just want to talk a little bit about what's going on. Everyone's really worried. You all know all the stuff about isolating and practicing social distancing. We all know all that, but I think a lot of people are really concerned about a couple things. Number one, I think we are worried about mortality rates and how fast they're going up. What is it going to be like here? Who gets sick? Who doesn't get sick? And treatments as well. So yeah, I guess I'll start with mortality rates. Mortality rates are pretty tough to really kind of pin down right now. They're very high in places like China and Italy. You're talking about rates, again, from anywhere from 4 to 8%, which is very high. If you consider seasonal flu has a mortality rate of about 0.1%. Now, the thought for coronavirus or COVID-19, because I got to be clear, coronavirus is around everywhere, but COVID-19 is the more lethal type that we're worried about right now. COVID-19 was always thought to have a rate about 1 to 2% or so. That is changing. I've seen charts that show a mortality rate of only 0.2 something percent in Germany, and in the US it's a little bit above 1. So we're on a growth curve that's hard to say where we're at right now. You've heard probably from the news that we're about 2 weeks away from this becoming really bad. And if you look at where the mortality rates and the death rates are for us compared to where Italy is, we are about, I would say, anywhere from 10 to 14 days. So what we do right now echoes for the future. The numbers we see right now actually only echoes what we did 14 days ago. So we can't be too complacent. So that's really mostly what I can say about mortality rates. We really don't have enough data to know. I really hope we're closer to South Korea and very low, around, I think it's 0.7 or 0.8%. But still, that's a lot of people. Now, that's the other thing, who gets sick. There's a lot of sort of conflicting information about this too. The people who are mostly getting sick, as far as we can tell, are mostly elderly people by, and elderly would be considered, sort of 60 plus, 70 plus, definitely 80 plus, and having comorbid conditions. What is a comorbid condition? It's anything that makes you less healthy. That's congestive heart failure, definitely lung disease, smoking, on oxygen. So that's one of the thoughts. A lot of people in Italy are elderly and are smokers. So that's why they did poorly. That's just a theory, not proven. If you have immune compromise from getting chemotherapy for cancer, those sorts of things are sort of what makes this worse for being sick and having higher chance of mortality. The rates climb tremendously once you look at the population above 50. Now, a lot of those numbers came from China. A lot of people say, yeah, can you believe those numbers? We don't. I don't trust China as far as I can throw it. And they probably hid a lot, or maybe not hid, I don't want to say hid, but they didn't test enough. Yeah, so I think sorry, just answering a, a text from someone who's trying to join up. So anyway, basically, that's what we have in terms of, I guess, mortality rates and the growth curve. So here's one other thing I want to discuss. The mortality rates and actually the infection rates and the overall what we call the incidence rates or the active case rates are really a result of testing. So that goes into testing. I want to talk about testing. Everyone's like, why can't I get tested? Why can't I get tested? I want to get tested. Everyone and their mother wants to get tested. And that's a problem for a couple of reasons. Number one, I agree, we need a lot of testing. We need a lot more testing than what we have right now in the US. We were really behind on this. I won't go into politics of why, but we just don't have enough tests, and the tests that do get done have a long turnaround time. So that adds on to the incubation period time. So we need a lot of tests. And actually, I believe the numbers that we're seeing in basically every single country, including the US, are much higher for incident rates. So we're at however many thousand right now, about 6,000 or a little more than 6,000 right now. I think we're a much, much higher incidence rate. And in other words, we're probably at a lower fatality rate for now because we haven't tested a lot of people that want to get tested or who are probably sick and aren't allowed to get tested by the hospital and the doctors. So that's one issue with relating to tests. So then the question is, well, then who can get tested? And that's a moving target. First of all, I wouldn't just show up at the hospital, because you show up at the hospital, they're not going to test you. They are going to send you home from the ER, or even if you're waiting there to get tested and you're trying to go in for something else to get tested, you will, number one, be not social distancing. Number two, you may be getting someone else sick who is really sick from something else, and that's something you don't want to do if you're only mildly sick. And number three, if you're not sick with COVID or coronavirus, you may get it from somewhere there. So you don't need to go into the emergency room to get tested. What I would say is call your primary care physician and wait and ask them, ask them clearly to get tested. If they are not contacting you in time, which is a problem, you can try another doctor, you can try another clinic. Ideally it will get better as the testing capabilities are increased. And my understanding is that we're getting about 400,000 tests every week. Now that's not enough. We need a lot more. I was reading things that Korea's testing about 20,000 people a day, and we're way behind on that. So in terms of testing is important. And guys, anyone there, feel free to write a question. I can't really see much from here. I'm not really sure how this works, to be honest. So I cannot see what's going on, but I'm learning the process, and hopefully it'll be more smooth the next time. So that's about testing. We do want to get tested. Right now, they're asking that people who have symptoms, number one, you need to have symptoms. So symptoms are what? Mainly dry cough, headache, fever, some GI stuff maybe. Most people don't have a lot of like runny nose or shortness of breath. Shortness of breath is a big one. If you have shortness of breath, fever, headache, cough, especially a dry hacking cough, those are symptoms. Then your possibility to get tested. Now you may ask, well, a lot of people have that, so why are they testing everyone that says they have that? There's a second criteria. Second criteria is you need to be exposed to someone who has had coronavirus documented, so symptoms and exposure, or symptoms and you're like a healthcare worker or someone high risk, or from an area of travel where we know there's a lot of things. So if you came in from like Wuhan, if you came in from Iran or Northern Italy, or all Italy, or France or Germany, and you arrived at the airport, or within the last 14 days you have these symptoms, then you would be approved to get tested, and they wouldn't send you home from the ER or your doctor. The other risk kind of thing that will get tested is sort of like a general thing of high risk being sort of doctor's discretion. So For example, you're like me, you're a healthcare worker, you've been exposed to a lot of sick people, you haven't really gotten exposed to someone definitely with coronavirus, and you haven't traveled from places, but your doctor may have a high, suspicion that you may have something just based on your occupation, or let's say you're a EMT, or you lead tour guides, a lot of people, and foreigners from another area. All of that is someone that would get tested. So that's who should get tested, but definitely we need more tests, and we need them now. And hopefully, as I update each day, that will happen. But again, something a lot of TV shows have said, and I agree 100%, be careful what you wish for when you get these tests, and they will have a lot of tests that are coming out and a lot more testing capability in every single city, every single state. Our numbers will skyrocket. We're not talking 6,000, we're talking, if we follow the growth curve of Italy, we will hit 10,000 by the end of the weekend. By the end of next weekend, we could hit 20 to 30,000. These are going to be astonishingly high numbers to freak out about. I would not worry about those numbers per se. We still want to look at the mortality rate. We want to look at, who is severe, and we want to look at hospital capabilities and ICU beds and ER stuff and visits and who's being overwhelmed, who's not. And that sort of brings me to my third point, which is general thing of hoarding. Now, we've talked a lot about, or you've probably seen a lot about how everyone's hoarding everything. Toilet paper, gosh, I don't know. Sanitizing wipes, hand sanitizer, food, like pasta sold out, rice, like canned goods are sold out. Everything's sold out. But the thing that is most important is masks, N95 masks, those things that doctors like me and EMTs and nurses need to be able to treat other patients are gone. They're hard to find even on the internet. And the hospitals have them locked down. We all have a certain supply, just like we only get a certain supply of flu tests or COVID tests, and we need that. The doctors and nurses need those things. So please, please do not hoard them. If you know anyone that has extra ones, please consider donating some, even if it's like 5 or 10. I mean, you don't have to go to the hospital if you don't want to. Hand them to a doctor friend that would use them, or a nurse, or PA, or even if they're anything, janitor, radiology tech, nutritionist, dietitian, anyone who's going to be walking around that hospital, which you don't have to go to. You don't really have to go to. Brian, okay, he just wrote a question. Brian from San Diego writes, there are celebrities getting tested with no symptoms. How are they getting these tests? Are there private channels that get tests, for example, from Asia? That's a little tough to say. My guess would be there's a couple things. A lot of these celebrities have private doctors, and private doctors have access sometimes to some of these things, or connections, or backdoor channels, or whatever. There are tests that are even coming out of Asia. For example, I have a friend in China right now, from Shanghai in Hong Kong. He's telling me their tests take very quick turnaround time. There's something like 3-hour turnaround time. If you go in to get a test right now in the US, it takes like 3 to 7 days to get that back. So there are tests available. Jack Ma from Alibaba is sending 500,000 tests over. So he has access to tests. And he's obviously a really rich guy who owns all of Alibaba and has billions of dollars. So long answer to the question, how are they getting these tests? Hookups, connections, private doctors, or back channel through just having money and other stuff. It can happen. Or you convince the doctor the right way. Another person was like Charles Barkley, let's say. He got tested, but he's elderly, believe it or not. I bet you he has some background problems, and I don't know what, but I'm sure he has some chronic conditions that put him at risk. And he is in a higher risk category. And I don't know his travel stuff. Maybe he went to somewhere, maybe he went to Italy or China, or had exposure to someone who is definitely a coronavirus victim. That automatically, those two things, again, like I mentioned before, would qualify him. So that's how some celebrities and rich people are getting tested. That's how, Trump got tested because he was exposed to, I think it was the Brazilian press secretary who definitely had COVID. For example, Vice President Pence has not been tested because he wasn't exposed to that. That's what they're saying, at least. So that's why people get tested, and that's why they don't get tested. So That goes with tests. So again, I was talking a little bit about masks. Please, please do not hoard. Do not hoard all that toilet paper, which you're not going to use, and which, by the way, Costco is not going to let you return. That's what I'm hearing right now. They're not going to let you return the toilet paper, the water, and the stuff anymore, and certain other things, and sanitizing wipes. So be careful what you buy. If you have extra masks, and you don't need them, I mean, how many do you really need if you're not going to the hospital? Please consider the people that need to use them, like me, that are going to be taking care of patients who are coughing in my face, who, I'm intubating, or that emergency EMT, ambulance driver is loading these people onto the gurneys from their homes, and they're so weak, and they're going to be in direct contact with them. They're the ones I worry about actually the most, because they may have the least amount of protection, and they're going to be the ones doing the intubations in the field sometimes. There's a lot more complicated medical stuff that I'll go into at a later date, but please, please, please do not hoard those N95 masks. Some of you may not really need them. I mean, honestly, if you're self-isolating right now, which you all should be doing, you do not need those masks in vast quantities. You need one, maybe one, for the time that you go out, and generally you could reuse some of them. I mean, there's a little controversy in that, but Okay, Gennady, I think from Illinois, is writing, can you discuss the promising treatments, chloroquine and Z-Pak? Okay, I was just going to get into that. So there are three major medicines making the rounds right now. All the back channels, all the doctors are talking about it, the news is talking about it. It has a lot of implications. This is separate from a vaccine. Let me be very clear. This is not a vaccine. We will not have a vaccine for maybe months. I wouldn't think we have it for months. They used to say like a year to 18 months, but I think we will have it less than that. They're rushing through a lot of things for better or worse. So this is not the vaccine. The treatments that he's talking about, the first one he's talking about is chloroquine and Z-Pak. And Z-Pak, we all know, you get it as a general outpatient treatment for pneumonia. That's for bacterial pneumonia. It shouldn't do anything for viruses, and this is a virus, but they are doing some research now looking at Z-Pak and chloroquine. What's chloroquine? It's chloroquine. It's an anti-malarial drug. It is very around there. It is very cheap, basically, and the side effect profile is relatively well tolerated. It used to be given as malaria prophylaxis all around the world. It's in every single pharmacy. Now, because it's looking like it's done well in some studies, and again, it's some studies in China that are retrospective studies, meaning they look back at trying everything, and it didn't. They didn't know what worked, what didn't work. Chloroquine has some very good potential. I would love if it worked. I would love if it worked, because we don't need to pay a lot of money for it. It's everywhere. We don't have to roll it out, and you could start putting it in for people who get really sick. Now, that's the other thing. Even if it was to work, should everyone and their mother go running out like everyone got ciprofloxacin when we had a bubonic plague, or doxycycline when we had a bubonic plague? We don't all need it, because we're all not going to get exposed to it. Or even if we get exposed to it and we are not sick, we don't need to take it. Why do you want to take a medicine just to take it or hoard it? Again, we're getting into hoarding. So chloroquine could work. We need more studies to show that it actually does, but it is on a lot of doctors' radars right now, chloroquine. The other treatment that was looked at, and I'm getting prelim information about this too in my back channels. I'm a part of a lot of physician, specifically COVID-19 physician groups, and I've talked to a lot of doctors about this and getting some of the most recent research, which I trust. One of the other drugs was Kaletra. That's a antiretroviral HIV drug, okay? And some studies have shown that there may be an effect there for treatment, not for cure, for once you have it. Again, all these things we're talking about, chloroquine, Kaletra, and the big one is the one Gilead is pushing for obvious reasons. It'll make them a crap ton of money, is Remdesivir. Or I'm maybe saying it wrong, but we may, all of these medicines, the prelim research is still coming out, and we need to do sort of prospective studies for them, and watch how people do who are really sick, who get these medicines. Number one, you have to figure out what dosage you give them so they don't get all side effects. Number two, you got to figure out like how long you treat them for. And number three, you've got to figure out if this is a real effect versus a placebo effect. You can't do a retrospective study. You got to do a prospective study before, the CDC and the World Health Organization and other people start telling, doctors, you may want to use this if you admit a certain type of patient. And that's the other thing. Number four, who gets this medicine? Is it going to be everybody? Probably not, because then there'll be a run on the pharmacies and we'll run out of that and the same problem all over again. Is it just the people who test sick? I would say probably not that either. Or is it number three, the people who really need it, who are admitted to the hospital, who are sick enough, and especially critical care? Maybe they're the ones that get it. I don't know any answers to any of this, but there are a lot of promising therapies. Stay tuned. I will promise to do the research on that and let you know what's out there, let you know what's real, what's not. Please don't believe everything on Facebook. At the very least, ask someone like me or anyone who has medical professional capabilities. I mean, preferably a treating doctor who's actually in the hospital, who is maybe especially like an internist like me, a hospitalist. I'm a hospitalist. I do acute care medicine. I help run the ICU. I cannot give you physical advice, again, personally, obviously for liability reasons. But I can definitely kind of tell you what's out there and what, generally we've been doing, what we're seeing specifically in Hawaii. That brings me to another point. Hawaii is very, very different from a Seattle, from a San Francisco, from a New York. My understanding is the hot zones meaning that we're really worried about spread, are places like Seattle, like Santa Clara, San Jose, San Francisco. That's why we have those curfews and mandatory stuff going on there. There's, I think, a cluster in New Rochelle, New York, and in northern New Jersey. Now, when I say cluster, I mean they're really watching that carefully. They may need to quarantine it, like physically quarantine it, not just suggest to people to self-quarantine. I don't have any information about that, and I think it's all second guessing. We have to figure out from the government what they're going to do. So that's really, we got to look where we're at. Again, you heard the numbers for anyone who's joining us later, 10 to 14 days behind Italy. And if anything, we're even maybe, a little even less time than that, because we are behind testing, and the testing has not maybe even been as good as Italy, and there's a delay in the testing of 3 to 7 days. Just be ready. Again, all the things that you need to do: self-quarantining or self-isolating, social distancing. So what does that mean? That means 6 feet away. Try not to touch your eyes and your face. We touch them like multiple times a minute every day if we don't look at it. Do smart things. Actually, someone asked me the other day, what about roommates? What if I live with someone and my kids are still, maybe not going to school, but they're going somewhere? We just went out to, go shopping, or, we had a family dinner. Again, you shouldn't be going to these big group events, but let's say you do come out, or you live with roommates and they come out and come back in. What should you be doing? I mean, personally, even clothes can be dirty. I would take those clothes off, honestly, right away and throw them at, within reason. You don't need to strip down in front of your kids or your friends or your roommates and stuff, but wash them and don't reuse those clothes. Take a shower, wash your hair, wash your skin, wash anything that had exposure. Even if you've been washing your hands and doing the hand sanitizer thing in public. Wipe down publicly used things. I mean, publicly where you are. Wipe down, I'm looking at my fridge. I'm the only one living here, but your fridge handles, the drawer handles, all the handles on your sink, all the dials on anything that you would touch that's electronic, your microwave handle, your oven dials, your, of course, your phone. If you can sanitize your phone and alcohol, wipe that, that'd be great. But there's a lot more things that we touch and then other people will touch, or that we touch and then touch our face. So the obvious things being obvious: door handles, sink stuff, but then other things that are not so obvious. Again, remote controls, again, drawer and refrigerator handles, even your laundry basket. That sounds really weird, but dirty clothes go where? They go in a laundry basket. They're not on the floor unless you put them right in the washing machine. That potentially, what are they? They're plastic. They could last there a little longer. So you need to wipe those things down, or you need to take it, shower them off. And, again, soap and water will kill this thing way better than just hand sanitizing it. We don't have enough hand sanitizing to hand sanitize your whole house, let's say. One more point. Someone also did ask me about temperature. A lot of people saying, oh, well, you know, temperature will kill it. And that's why these southern countries and places like Hawaii and, you know, Africa and whatnot are doing much better right now. It's all cold in Europe and Italy and China and some places. I would be very cautious about using temperature as your protection because number one, you don't have a lot of control over the temperature where you're at. So you just got to treat it like you may have it around you or you may not have it. It's sort of all or none for you. You can't depend on the temperature in your area. I mean, it's 80 degrees sometimes in Hawaii, but it's kind of colder right now. It's rainy. So what are you going to do in that setting? You know, heat may kill it eventually. And we may find out later that there are lower rates in hotter areas and higher rates in colder areas. But, you know, very simply, you can look at a place like South Korea and Japan. They are very cold right now. I mean, it's, you know, or colder. It's March. It's still pretty cold. They have much lower rates than a place like China and Italy and even Iran. So it's freezing cold there. So why aren't the rates through the roof there? Now, that has to do with them being much better testing. South Korea's drive-through testing. Japan, I have a feeling, I've discussed with some friends, they may or may not be testing everyone. You know, the same way that China's, you know, overall, you know, cases are probably very, very high, very, very high. There's a time they're sending back people and just telling them to self-quarantine because they couldn't deal with the rush into the ER. Again, do not rush the ER to get a test there. Before you get a test, call your doctor, get it approved. Because I'm telling you, they're going to send you home. They will send you home because there's not enough tests for each state right now. And they're trying to get them there. When we get to a point where there's a test for, you know, half the people in the state or, you know, even a quarter of the people in the state, they'll start relaxing those restrictions on who gets tested a lot more. Then maybe it'll just be anyone that has a cough, fever, you know, and was exposed to someone who was sick even. Maybe that will be it right one day. But right now, that's not what it is. They don't test you just because you are exposed to someone sick. A lot of people have been telling me, even healthcare workers, nurses, doctors were next to a sick girlfriend or, you know, went on a date and the date sneezed on them, you know, and now they're freaked out, you know. Technically, are they going to get tested? Not always. I mean, that's a doctor's discretion, as in your own personal doctor. Even doctors have doctors, nurses have doctors. So that is, that's what's going on right now in terms of testing. So I'm going to, you know, one other thing, I want to talk about a couple more myths that are coming out right now. And a couple of these are really interesting. I wrote a couple of these down. Number one is the hold breath test. I'm sorry, I know I just touched my face. I washed it. That is the most ridiculous thing I've ever read. The hold your breath test to see whether you have COVID-19. That's ridiculous. If you're short of breath, that doesn't mean you have COVID-19. It means you're short of breath from something. You could be short of breath from anxiety. You could be short of breath from the common cold or the flu or something else. So should you get tested just because you can't hold your breath 15 seconds or whatever it is? No, that came from some chainmail, supposed Stanford thing. It's garbage. Please do not listen to the internet about this like breath stuff. That's ridiculous. Please don't do that. Even if you do it, that's not suddenly your signal to go flying to the emergency room. Number two thing I heard was there's some interesting, gargling with salt water, and you will kill the virus or something like that. Okay, there's zero research on this that I know of, specifically coronavirus at least. It will make you feel better. It might symptomatically help stuff. But once that virus has touched a mucous membrane, that mucous membrane is anything, your eyes, your nose, your ear, your mouth, use your imagination, anything mucous membrane, it's in. You're not going to suddenly salt gargle it out of you. It's not going to happen. It will not happen. It'll make you feel better. You feel a little salty. That's about it. So the salt thing is not going to work. I know people want home remedies. This is not about a home remedy thing. That brings me to another point. So a lot of people are asking, what medicines can you get? And again, please do not hoard these medicines. I have 4 medicines I would generally recommend that you have. Again, supply of just for you and your family. And I hope you have some of these things already. If you don't, get a little bit of it. If you want to prep, but please, again, do not hoard, because there are places that are limiting it. Switzerland is limiting some of these medicines. And these medicines are acetaminophen, or paracetamol, sometimes it's called in Europe, or Tylenol, as it's better known. So you can get some Tylenol. It's in part of a lot of cold and flu medicines. Number two, for the cough, to prep for it, you can get something like Robitussin DM, or the generic is guaifenesin dextromethorphan. That's sold out a lot of different areas. I've seen Mucinex that can help as well, but that's more for the expectorant, meaning being able to cough out something. The guaifenesin is the active generic ingredient that helps prevent the cough for a bunch of medical reasons I won't go into, mostly dealing with reflex and brain pathways. So guaifenesin and Robitussin DM / Mucinex DM, these things are good to have. Please do not hoard them. We're running low even at Walmart, and some old lady's gonna need it, and she's not gonna get it, and she'll end up in the hospital, and you're gonna feel really, really freaking bad. Or maybe you won't, because you won't know she's in the hospital being intubated right now. So that's number two medicine. Number one, paracetamol. Number two, guaifenesin DM, or dextromethorphan, or Robitussin DM. Number three is a symptomatic medicine. It's just menthol cough drops. That's Hall's cough drops. That will really help soothe that cough. And by soothing the cough, it will help prevent you from feeling pretty bad. Sore throat, if you've got some sore throat, or cough. So that's the number three thing, is cough drops. Number four thing, and there's a little less evidence for it, and it's also getting very sold out, but it wouldn't hurt necessarily in most cases, is stuff like zinc tablets. Coldies, a lot of people know it like that. But zinc gluconate is a generic. If you can find it somewhere, you can get the generic brand, then again, get one thing of it, for you and your family, so that if you need to use it, you can use it. But please do not hoard these things. Especially do not hoard the paracetamol, Tylenol, acetaminophen, and do not hoard that dextromethorphan, guaifenesin dextromethorphan. Someone's gonna need it, and that old person is not going to get it, and they'll touch the shelf looking around for it and maybe forget to wash their hands, and then they're gonna get sick. So please do not hoard that. So let me go into some other last interesting findings that we're finding in research. I've read some studies, and you'll probably see this very soon, about blood type. Blood type A versus blood type O, and blood type A is more likely to get sick than blood type O. Now that freaks everyone out because it divides us, because we're all either O, A, B, A, or B. This is like some Korean movie stuff. If you don't understand what I mean, ask a Korean friend about blood types. There's a study out of, I think it was China or somewhere, that people of blood type A were more likely to get it. Again, this is a retrospective study. It was something, but it was like 80 patients versus like 60 with blood type O that got it. That is not really a statistically significant difference or a good sample size. Is it possible that there's some difference between how many people of blood type A versus blood type B versus blood type AB versus blood type O, plus or minus, or positive or negative? Because again, you have that, designation, whether they get sick or not. It's possible, but right now it's too early to say this. The news loves printing this stuff because it's like clickbait, and people love spreading this stuff because everyone can relate. It's like, oh my God, I'm A, I'm gonna die, I have it. Or it's, oh, I'm fine, I can go party on the beach right now. Just wait it out. And anyway, if you have it or don't have it, it doesn't help you, right? It really doesn't help you. You should still be self-distancing and social distancing and self-isolating right now. Number two interesting thing that we're finding is about ibuprofen. You may have heard a lot and seen a lot about ibuprofen, and we're not supposed to use ibuprofen now. It's on the CNN front page thing. It's people, and this comes from a study out of France that was originally comparing stuff like ibuprofen in COVID patients and how they did, and they supposedly did worse. Again, these are all retrospective studies. They've been throwing everything at the patients, and some patients did worse with ibuprofen. There's some question about whether anti-inflammatories in general that are also like, let's say, Vioxx and Celebrex and any other what they call NSAID, non-steroidal anti-inflammatory, is bad for you. So ibuprofen may be worse. I personally, I don't like using it because it's much worse for you for gastritis. It causes a lot of stomach upset if you don't take it on a full stomach, and even if you do take it in full stomach. And if you take it in too high quantities, it can cause kidney problems. So don't take it all the time, and don't hoard it. I mean, all things being equal, I would rather use acetaminophen or Tylenol, yes. But it's not to say that ibuprofen is much worse. I just think it's a better tolerated drug. The people who should not use Tylenol are people who have liver disease or elevated liver tests already, or in combination with some things, or rhabdomyolysis, muscle breakdown and some stuff like that. So, but generally, I would rather use Tylenol than ibuprofen. Last research thing, and probably where I'm going to end it today, because this has gone on almost till 5 o'clock, unless someone wants to type in more questions, is there's another study that's talking about the negative effect of ACE inhibitors. What are ACE inhibitors? ACE inhibitors are basic, well-tolerated blood pressure medicines. Lisinopril is a major one that most people use. It used to be Captopril. They also have enalapril. I mean, some of these are IV, some of them are regular. The one that most people probably have heard of is lisinopril. It's a blood pressure medicine, and medically, I won't bore you with it, but it controls blood pressure by acting on certain receptors in the kidney. Now, there's some data that's saying that ACE inhibitors and lisinopril are bad, and we shouldn't be using them for any patients, or you should get off them right away. Again, we got to look at that research more. This is all retrospective studies. These are not prospective studies where you've seen what people on lisinopril and off lisinopril do going forward. You're only looking back at the data. It's not a great, and again, there may not be many numbers to, that match that up. So lisinopril is also, or ACE inhibitors are suspected, like ibuprofen, to maybe not be great. But would you stop people from using them? I don't know that you'd stop people from using them just regularly, normally, but if they were sick with COVID-19 in the hospital, would we stop ibuprofen and ACE inhibitors? Probably we would. Probably we would at this point, only because, as you figured out, everything changes day to day. The new data that comes out changes day to day. The growth curves change day to day. The research comes out day to day. The CDC recommendations change day to day, if not more frequently. So we don't know right now. We're just stay tuned, and we'll figure it out. So I think I'm gonna slowly wrap things up right now. Again, I don't wanna summarize everything. Hopefully this was too long. I'll try to make daily podcasts so I go back to work. I go back to work next Tuesday, and then I will be in the hospital in the thick of things. People sometimes ask me, how's Hawaii? Someone was telling me a rumor, 500 people in the emergency room. That was garbage. There was 500 people at Costco. There are 500 people at Costco on a normal day. So it was not the hospital. And that's why I'm saying, please stay out of the hospital if you don't need to go. Unless you're emergent, unless your PCP tells you to go, or you got those really bad symptoms, especially really bad shortness of breath, high fever, exposure to someone who definitely had COVID-19, or you came straight back from Wuhan, China, or Italy or something like that. So then you can go get tested once you get some approval. But anyway, I think I'll sort of leave it at that. But oh yeah, sorry. So Hawaii, we're doing okay so far. I mean, we're ramping up testing. We're definitely behind. We have very few numbers. I think the last number I saw was 14 in the state. Nobody died. Most of those are in Oahu and spread out around the islands. What's my true thinking? I think the number is way higher. I really think right now we have about maybe even a couple hundred asymptomatic patients who haven't been tested. We haven't had anyone die. That's why I don't think our numbers are like in the 1,000 range or more. If with a mortality rate of 1% to 2%, again, you would expect 1 to 2 people dead generally. Like I'm sort of simplifying the statistics. If we were in the 1,000 range. So where do I think we're at? Hawaii is way more than 14, way less than 1,000. That's where I put it at right now. We're somewhere in between. That's all I could say. My guess is low hundreds, but I have nothing to back that out on, and hopefully we will see as the testing goes along. So that's it. I hope a couple of you found this helpful. And I'll push the advertising now. Please forward this to any of your friends, especially your friends and family who freak out on Facebook. I know you know who they are. Again, have them like my page or sign up for the podcast every day. I worked out the technical kinks. I can now do the live broadcast all the time on It'll be on Facebook Live. You can also add me on Instagram. I set up a new Instagram account. It's at @thetraveling_MD. Again, at @thetraveling_MD. And I'm also on Twitter, which I'm really not using right now because I'm mainly going to use Facebook as @thetravelingdr, @thetravelingdr on Twitter. So that's it. Hope you guys have a little more information. Stay safe, wash those hands. Yeah, social distancing, self-quarantining. I'm in day number 5 right now. I have not gotten out of this place for 5 days, except for minor shopping and you know, very important things like doctor's appointments and stuff. That's it. I have not left for 5 days. I know it sucks, but I've caught up on movies. I'm gonna start playing some video games, and I'm productive. I set this up, and I hope that other people do the same. But again, hopefully it's helpful for some of you people, and feel free to forward along. Again, I am Dr. Albert Lin signing out, the Traveling Doctor. Thanks, aloha, and stay safe. Okay, guys?